with my stupid jokes. All right,
we're live. Edit that out.
Yeah, I can't edit that. Well, you're not going to be able to edit this out.
But you can fast forward through it.
You can. Hey, everybody. Thanks for joining. I think this is our 8th Tuva Project community meetup. We are super excited for this one. We're going to showcase a bunch of open source stuff we've been building into the open source around analytics to support Medicare ACOs. This is all made possible via our collaboration with UPenn, and we've got Dr. Zeke Emanuel and Daniel Shenfeld from UPenn to here with us today, and we're gonna chat with them about it, and then we're gonna dive into a demo of what we've been building. Just a little bit of housekeeping before we get started. If this is your first Tuva community meetup, or maybe you don't even know what Tuva is, we started the Tuva Project a couple of years ago, basically based on this idea that it's really hard to do healthcare analytics because there's a lot of different tools and a lot of domain knowledge that you need to do healthcare analytics. And we just wanted to make that stuff open source so that we could help all healthcare organizations do high quality analytics and kind of lower the barrier to doing that. So that's what the Tuva Project is. If you go to the tuvaproject.com, you can read about all the different tools that we open source. It's a lot of basically there's a common data model for claims and analytics data. There's all the different terminology sets. There's a bunch of different data marts that create measures and groupers and apply things like the CMS HCC risk models. But basically the idea is, how can you go from raw healthcare data sources like claims data, EHR data, other types of clinical data to healthcare analytics like analyzing cost and utilization, analyzing clinical quality, risk adjustment, things that every healthcare organization needs to do. And so with Tuva, the code for doing these things is all open source, and we've built it to run inside the modern cloud data warehouse. So there's more than 75 organizations across the US today that have implemented Tuva in production, and they're running all of this inside their Snowflake, their Databricks, whatever their data warehouse is, which lets their data team have kind of full control and transparency into all their data and the transformation of that data. We also have an open source community, a Slack community, and you can see, you can go to this community just if you go to the tuvaproject.com and you click the Slack icon in the top right, anybody can join this community. It's totally open. There's a little over 2,200 healthcare data and analytics engineers, data scientists in the community today that are just contributing to the build of this project, and we have active conversations in channels like Builders Ask, like around, how to implement Tuva, what's the right way to do different types of healthcare analytics. So it's a really kind of active conversation. And if you're a healthcare data person and you're looking for some community like this, I think you'll find that Tuva is you might find your home with the Tuva Project. So with that, let me full screen this. I think you guys are seeing this. So here's let's jump into the agenda. I just went through the kind of intro housekeeping stuff. And we'll now I'd love to go to Zeke and Daniel to talk a little bit about our collaboration. Zeke was able to secure a philanthropic grant that made all of this possible, and he and Daniel really spearheaded this collaboration. So Zeke and Daniel, maybe you could take a few minutes to just introduce yourselves, and then share a little bit about what you saw the need was in terms of like analytics, what the gap was for analytics and value-based care, and why this was really interesting to you guys.
Yeah, thanks, Aaron. I see that Zeke is on. Zeke, are you able to turn your camera on?
Oh, my camera's not. I can see myself.
There you are. I see you.
All right. Sorry. So I'm Zeke Emanuel. I'm a health policy guy working on a variety of questions of how to improve healthcare. I'm one of the original people who helped draft the ACA, and I pushed a lot of the value-based payment components that are in the ACA because I believe we had to fundamentally transform the incentive structure to get better care at lower costs for more people. And I've been pushing all sorts of, demonstrations, but also the things like when under the Biden administration, they committed to having everyone in accountable care organizations. And MSSP is one of those things that I was part of the creation team. So one of the things that has become clear to both Daniel and I is that there are a lot of Medicare or CMS was not doing a great job of helping physicians actually try to perform at their best, even when they were well-intentioned and they needed help. They needed information, and the information that CMS was providing was well nigh worthless. It was not information, it was a data dump, and a data dump that for regular docs, I'm a regular doc, is you just can't. You have to either spend a lot of time and be an IT guy, or you have to spend a lot of money to get an IT guy who's going to do all the informatics. Plus, it wasn't helpful in making future projections. One of the things that Daniel and I, it's not a shock, but under fee-for-service, exactly what you have to do to make money. And you know how many widgets you have to do and what profit is going to be, etc. Value-based payments a whole different ballgame, right? You're making money from not doing stupid stuff, doing stuff that is actually going to both be good for the health of a patient and save the system money. That's not obvious, and it's not obvious when you've succeeded. But to understand whether you're succeeding requires a lot of data that isn't being provided. So we thought, look, could we take the claims that CMS is now providing, and could we automatically make dashboards for doctors that are dashboards everyone needs to operate their system and to improve what they're doing? Identify patients who are high cost, identify patients with diseases that aren't being optimally managed, where the gaps in care are. And can we create that kind of information that is available to everyone like that without hiring someone to do all that work and spending a lot of the money that you might end up saving the system on IT support? So that was the idea. We got Bill Gates' team to buy into, all right, try to make it and see if there's interest, both on the receiving end, ACOs and doctors, and on the producing end, CMS. Can we prove to them that it would be valuable to do this? And the other really important element is, can you make it the adoption sufficiently easy for CMS to do so that they can't, which I learned for many years working with them, they're constantly technology and human resource challenge. They don't have that many people, and their technology sucks. And so you have to give them something that can be more or less plug and play. So that was the insight. Now, I'm just a health policy guy. I am totally stupid when it comes to IT. That's why Daniel is here.
Thanks, Zeke, and thanks, Aaron. So I'm Daniel Shenfeld. I work with Zeke at UPenn. My background is more on the data science and technology side, and so the projects that we work on together are primarily around how can we use data and improve and improvements in technology to help drive value-based care expansion and help value-based providers. As Zeke mentioned, this particular project came from our observation that it's actually very difficult for ACOs to run basic analytics. In my other hat, I'm a consultant working primarily with value-based providers, and after having worked with a few ACOs and seeing how much work goes into producing even basic reports, it was pretty clear that this is a big gap. And not something that is directly addressable by the data that ACOs receive from CMS. In our estimate, it takes anywhere between $500,000 and $1 million for an ACO, depending on the size, to be able to process all this data. And that's, as Zeke mentioned, is data that's just wasted out of the system. So that's the origin of this project.
And Daniel, when we were first, when you first like take me back down memory lane, like how did we come together? How did the idea to collaborate with Tuva kind of come together?
I was thinking about it ahead of this meeting. Aaron, I think that you and I have known each other for maybe 5 years now, and always in sort of a casual way, but didn't really have the opportunity to work together. Ultimately, the community is pretty small. At Penn, we had obviously used Tuva for various other projects where, as you said at the beginning, the goal of Tuva is to lower the barrier to entry, right? And so on various other projects that we work on, it probably saved us 6 months or more of just data wrangling. And so when we were able to secure the funding, it was a pretty natural opportunity to collaborate. So from the get-go, it was obvious to me that we were going to build it on top of Tuva's open source. And so while we're doing that, why not just have it as part of Tuva? And I think you and Coco and Paul were very aligned from the very beginning. And I think it's been a very fruitful collaboration.
Yeah, for sure. And maybe say, and Zeke, feel free to chime in here, say a little bit around how you think about this phase of the project and what the broader vision is here, where you would like to see it go.
So look, honestly, the ultimate goal is, getting CMS to adopt software and put it in that's open source that will give you guys a set of dashboards based upon your data. So instead of data dumping you, giving you the dashboards that you need. And then we imagine there will be a lot of other programs that can be built on top of it, programs that'll help you understand if you manage this patient better, here's the kind of savings you can realize. Those kind of forecasting programs that are essential to succeeding in things like MSSP. What those are, that's going to be, the imagination of others. Part of what we've confronted, honestly, at CMS, when we've talked to them about this, is, is there a community out there where this would be really helpful? They're kind of skeptical. Why should CMS do this? Are there people who really would like CMS to do this? I find that skepticism hard to understand, but, I'm not a government bureaucrat. Partially, it's, I think, look, we've got a lot of demands on our time and our technology and our technologists. Show us that this will be really, really beneficial to the community. And remember, let me just give you the number of ACOs in Medicare has plateaued, and the number of patients has plateaued. And that's actually a bit concerning to CMS and counterproductive. And I think what they don't understand is big groups can afford, $500,000, $250,000, whatever it is. Small groups can't. And you're excluding lots of smaller groups that can do a terrific job and really know their patients by, just data dumping. So part of this is, is this of interest? How could it be modified to make it of even more value to you? And what can we do? Also, we have some software now, but we're constantly in the refinement stage and the improvement stage. What else would be helpful? So that's how I see it.
Yeah, maybe I'll add that making the software open source goes a long way, but you still at this point need someone who's like an engineer who's able to actually install the software and getting it to run and so on. And Aaron, when you and I started the project and we're looking for ACO partners, we got a lot of interest, but also pretty clearly we ran into these barriers that, well, you need to sign a BAA, you need to go through InfoSec, and
yeah.
And so making all these capabilities truly available to everyone, and some of the ACOs that we spoke to, I know are also on this call. I think that's the real goal. So I think that the technology is there with the demo that we'll see in a moment, and hopefully we can make it available seamlessly. The goal is to make it free.
Yeah, 100%. Okay. Any parting thoughts before we jump to Paul and Mike and start to get into the demo?
Hey, Zeke and Daniel. Can you guys hear me?
Yeah.
Hey, this is Will Gordon. I'm one of the bureaucrats, as Zeke mentioned. I'm a physician and informaticist at CMS. Just want to put a finer point on what Zeke said. We're here, we're watching. We are excited about this. We've actually been following Tuva since your funding announcement a year ago. We actually do have a somewhat modern stack at CMS. We have Databricks and Snowflake, and so just to reflect on that, I know Zeke, you're not a technologist, but just to emphasize that a lot of our tech actually is. We have a production file server, et cetera. But I think just to put a finer point on what Zeke said, I think the question is not so much, are these things valuable for ACOs? We know they are. We know that many ACOs are partnering with enablers that make them successful. We know there's a bias towards larger ACOs that have the resources to do that. That is very clear to us. I think the question is this specific product adding value? And so that's the question, right? It's not the general concept. It's, does this add value? Does this specific functionality add value? More so than a lot of what the enablers add, which is a very strong services layer. So just to put a finer point on that, we're excited about this and really looking forward to the demo, and thank you for organizing it.
Thank you for correcting me. It wasn't clear when we talked that you guys were interested in this tech.
No, we are. Again, we've been following Tuva in particular. We're very much into open source. We have an entire open source office at CMS. We've open sourced our shadow bundle logic. It's all SAS code, but it's there in GitHub. So this whole initiative is very exciting to us, and again, appreciate the energy behind it and the opportunity to see what you've built.
Great.
Awesome. So I hear a lot of alignment behind this. We're ready for the demo. Paul, Mike, why don't I turn it over to you guys? Just for context, Paul and Mike did a lot of the background work, the actual development work in conjunction with our ACO development partners here. So I'll let you guys introduce yourselves and then kind of take it away.
Sounds great. Well, yeah. Thanks, Aaron, and thanks, Daniel and Zeke. This has been a great project for Mike and I to be involved in. Without going through our whole bio, basically, Mike and I have worked at health plans and worked together in a number of capacities. But one of the common themes is we're always working with this stuff, and that's honestly how a lot of people find Tuva is you're trying to clean up claims and clinical data, which is notoriously messy and complex and nuanced. And so we've spent a good amount of our careers trying to ingest that data for payers or providers that we're working with that are taking risk, and basically build dashboards like the one we've built here to be able to understand what's driving cost and utilization in a population, understand where gaps in care exist, and understand how to get that information in the hands of clinicians and providers to do something about it. So that's kind of the background on us. But Mike and I, done a lot of the technical work, the analytics work. It always goes better when you partner with someone who really understands what is trying to be done. So I did want to just introduce a couple of development partners that we found, 2 different ACOs who have allowed us to come in and work with their data and get their feedback on how this is built. So it's not just, a bunch of guys sort of ideating from a tech standpoint on how to do this, but actually how can we do this in a way that is really meaningful and helpful to the ACOs that are trying to manage populations. So we have with us today Joy Bender from Multicare and Marvin Gallo from Value-Based Care Advisors. I'd love to just allow you each to introduce yourselves and your organizations as we get into this, and then we'll point out where they've given us feedback in the components of the dashboards. And I do promise we're getting into the demo here quickly. Joy, why don't you go first?
Hi, everyone. My name is Joy Bender. I'm Director of Data Science here at Multicare, focusing on population health and value-based care. Over the past year, my team's been working closely with Tuva to advance our unified population health data strategy. And a big part of that effort has been this development partnership with UPenn and building out and helping just advise on their progress over the ACO analytic dashboard build. We've brought together a team of some of our med econ, risk adjustment, clinical quality, to help partner and help give feedback to this team. It's super exciting because it aligns with our goal of creating scalable, interoperable solutions that drive actionable insights for ACOs and clinically integrated networks. And so we're excited to share our progress and learn from this community, as well as we continue to build those tools to empower providers and improve patient care is what we're all trying to do, right? So excited to be here.
Thanks, Joy. Go ahead, Marvin.
Hi, everyone. Thank you so much for having me here today. My name is Marvin Gallo. I'm the founder of Value-Based Care Advisors. We operate a qualified clinical data registry and a national ACO. And really, our whole focus is on helping independently owned medical practice manage their MIPS and quality reporting, and ultimately transition them into value-based care models. I'm super excited to have had the opportunity to work with Paul and the Tuva and Daniel, the Penn Medicine team, and to have been able to bring my perspective, which is from a startup ACO. We're a very small operation. We have currently about 6,500 lives, and we were fortunate to receive an advanced investment payment AIP from CMS. So to the CMS folks, I just want to say we're very grateful for that program. And we're also very grateful to Aaron and the team for making all of this open source, because really, Daniel and Zeke, you guys are correct. It does take somewhere between $500K to $1 million to be able to do the work that you guys are doing here. And we look forward to utilizing, redirecting our AIP dollars towards care coordination support, which is really where we feel our providers and practices will benefit the most. And so having this foundation and having had the opportunity to collaborate and giving our feedbacks and giving insights into the things that we see that we truly need as a small ACO has been a phenomenal opportunity. So thank you.
Great. Thanks, Marvin. So the last thing I'll say, and then we'll dive into the demo here, is just, as I think a few folks have mentioned before, basically all of this is possible. The ability to share this in an open source way and make it easy for ACOs to test out, leverage, and use for free is because of the Tuva Project. And the Tuva Project is basically a data model, as Aaron explained, that brings together a bunch of constructs and concepts like diagnosis code descriptions, which don't come on claims. So if you want to know, what that code means, you have to bring that data in. So all of that is done as part of the Tuva Project for you. And it's a very simple sort of mapping process. The data gets constructed. We have built a layer on top of the Tuva model that makes this all work really seamlessly in a BI tool like Power BI, which is what we'll be leveraging. And we can go into depth on sort of what that takes, but suffice to say, it's much, much easier than doing it sort of basically from scratch. The other thing I'll say before we dive in, kind of in response to Will, and thank you for chiming in, is that actually because this program is run through CMS, you have actually a very predictable set of raw data that's robust in the form of BCDA or CCLF files that come on a regular basis and are typically much higher quality than we see from a lot of other sources. So that is to just kind of put a point on it. It makes it a lot easier to build something like this. So I'll stop there. I'll hand it over to Mike Krahulik, who's my partner and hasn't introduced himself. We've been working together, but at Tuva on this project, and he's really the brains behind the whole operation. So Mike, go ahead and walk us through the dashboard.
Sounds good. Let me share my screen here quick. All right, can everybody see?
Yep.
Awesome. I just hit everybody's video, so it's easier to see the dashboard, so I can't see you anymore. So chime up or speak up if you have any questions or want me to walk through something in more detail. So I'm Mike Krahulik. I've been working on this project for the last few months, and excited to share our current results. We're going to walk through at a high level 2 kind of primary entry points into our ACO dashboards. The first will be a cost and utilization dashboard that is really meant to kind of give you that top-down view of your cost and utilization for a particular ACO population. And then we'll pivot to a more performance-oriented dashboard that's really meant to allow you to break down these same costs, but then looking at it from a practice, provider, patient level, looking at very specific, actionable gaps and quality measure information that a physician could use when speaking with a particular patient. So we'll start first with the cost and utilization dashboard. This will give you a nice overview of kind of how the Tuva model works. What the Tuva model provides out of the box is the encounter grouping. So, categories that we're all pretty familiar with working with, inpatient, outpatient, office-based, other, and then encounter types. So subcategories of those encounter groupings that help you understand the specific types of utilization. And then condition categories. So looking at those same claims and the diagnoses that are attached to them and looking at what is the primary, condition that's responsible for that particular claims cost. So if we, start to look at this is looking year-over-year comparison of costs. You could also look at the cost and utilization compared to benchmarks, whether you're receiving them from an actuarial firm, looking at them based on the benchmark information you receive from CMS. Those can be loaded into the Tuva project as well for comparison. But if we're really interested in, inpatient costs, if we drill through, we get an inpatient specific view. We have specialized views for all the other encounter groups as well, since there are different, types of ways that you'd want to look at the utilization. If it's inpatient versus outpatient versus office-based, obviously very different types of utilization. So for the inpatient dashboard, we're, looking at our top level DRGs, looking at our top facilities. We can begin to, filter down if we're, looking at septicemia. We can highlight the actual facilities that are having disproportionate costs, seeing if there are any that we might want to, dig in further and do some more ad hoc analyses on, or if you're, vice versa, really interested, okay, Oakwood is our highest, cost. What are the primary DRGs that are causing that utilization? Again, being able to start to, slice and dice the information to allow you to, really hone in on, yeah.
Maybe I'll jump in to say that this is a made-up ACO from a representative sample of overall Medicare claims, which is why you're seeing facilities from all over the country that are not necessarily actually grouped in a real ACO.
Yeah, thank you. We've had to sort of randomly assign and select members, and then the second dashboard will use purely synthetic data so that we don't have any danger of showing PHI. It's a good call out. Thank you, Daniel. But yeah, some of the geographic dispersion of things doesn't necessarily make sense in the way that you might in a natural ACO. So then, we have a similar sort of breakdown if you're looking at a particular condition, if we're, interested in why hypertension is, popping up and, really trending year over year, we can drill through to that very specific condition. Now we're looking at claims where the primary cost driver is hypertension. And again, we're getting that similar, view and breakdown with a few specialized breakdowns from there. So we're seeing that it's causing, $33 PMPM towards our overall PMPM costs. And we can similarly start to break this down. So if we're really interested in, where we have both hypertension and chronic kidney disease, we can flag that and begin to dig deeper and understand the facilities and types of care that might be causing the highest levels of utilization. So in the interest of time, there's a couple other views we could highlight here, but we'll actually hop over to the program performance dashboard. This is again that really actionable view that we're hoping would really be used in the hands of operators, both like a CFO level view, and this was something that we really designed in partnership with Marvin from BVCA, all the way down to specific patient and provider views where you might be looking at your actual panel. So at a high level here, we've broken down, a variety of different measures that are important to understanding ACO performance. So we're looking at PMPM cost compared to, benchmark or comparison group, looking at average risk score and how that's trending year over year. Again, this is synthetic data, so risk score is a little bit lower than you might expect. And then also looking at quality measures. You have the ability to bring in targets for the quality measures, whatever target would make sense for your particular organization. And then we'll dig in a little bit more deeply in quality measures and what's available and what's still in development after we've dug into the actual dashboard views. One thing to highlight, again, this is synthetic data and we've randomly attributed members to providers and then providers to practices. The Tuva model does have an input layer to allow you to use really an arbitrary attribution model. So you could engineer the MSSP attribution model, or if you're doing that internally, we know that doesn't actually have the sort of patient level attribution today that you would need to do this. But if you have logic that you've created based off of the documentation from CMS, you can implement that here, or use an arbitrary attribution logic. So if one of the challenges that we've heard from ACOs is that sometimes the attributed provider isn't necessarily the person that's in the best position to close gaps and manage that particular patient. So if you are looking to, try to find more of a primary care doc that is best positioned to do that, you can create your own attribution logic. Or if you're a small ACO, you could do that manually if you're in position to be able to do that.
And just chime in here, or maybe Joy, if you're still on, if you wouldn't mind chiming in. I think multi-care has, in many ways, quite a sophisticated way of viewing this, but some of the challenges they've been dealing with are likely those experienced by other ACOs with regard to sort of identifying the right providers and practices. So I don't know, Joy, if you want to talk a little bit about.
Yeah, sure. Yeah, no, attribution is a really important piece here. CMS does provide the logic to calculate how your member has been provided. And so that has to be implemented, but just as Mike mentioned, sometimes that isn't enough necessarily to know who's really in charge of that patient's care, right? So if they saw a specialist, that maybe then that's why they were attributed. That specialist may not be the one who's actually guiding their primary care. So a lot of organizations will develop their own internal custom attribution, which we're actually in progress developing internally here. And what's great about the data model that supports this is it allows you to have both, and so you can you'll be able to have the ability to use either the CMS or custom. So really excited about that.
Awesome. Yeah, so I think that's a good sort of overview of kind of how the attribution is happening, but we've done it in a way that helps this dashboard, function well and be representative, but, there's some sort of devil in the details to attribution that we figured we'd highlight. So now if I'm an ACO manager, managing a variety of practices or providers, this would kind of be the starting place for me to understand, how ACO is performing compared to benchmarks and where we maybe have some opportunities. So, if we're looking at practice F here, we're seeing pretty high PMPM changes year over year, even higher than you're seeing in the risk score or change, and then relatively low performance or pretty low performance on the quality measures as far as what they're meeting. So maybe we're interested in digging deeper into practice F. So now we're into practice F, again, only looking at their assigned beneficiaries. And we're starting to see the provider panel. This could be, arbitrarily large right now, just to make it a little bit more manageable. We've only got 6 providers at this particular practice, but it would show more or less providers depending on the size of that particular practice and that particular ACO. And again, we're seeing some similar information. So we've got a couple of providers that, have pretty substantial PMPM changes year over year. And maybe we're interested in provider P because they also have that lower, quality measure score. So this is when we get to, some pretty actionable information where you could actually put this in the hands of a particular provider. And we're displaying both their performance on specifically quality measures, as well as their outstanding risk gaps. And then their actual patient panel. Again, this is synthetic data, so no actual PHI is being displayed here, but it does give you a look and feel of how this might look for an actual patient panel for a provider. And there's a couple of different ways that you can start to dig into this. So if we're interested in, why, what outstanding gaps we might have in the pain assessment and follow-up measure, these are the currently available quality measures that we have for the Tuva project, but we're in progress to develop the actual MCQM measures so that they align directly with what's required of the ACOs. So use this as an example, but the measures themselves are still in the work in progress. So we can actually drill through and actually get a chase list of all the particular members that for that provider, for that practice that we might need to follow up. And you can get to the patient specific view through this actual chase list. But we'll go back there in a second. And then our outstanding HCC gap. So we can see which particular diagnoses are causing the largest gaps. And then again, we can drill through, get an actual chase list of the specific patients that have that gap outstanding. If you're going to begin to work, a list and have some outreach occur. And then, the other sort of way of looking at this is you're just analyzing your panel, looking at which of my patients are having the highest costs. We have, each patient listed, their age, conditions, risk scores, outstanding risk gaps, and quality measure performance. If they, some particular patients don't qualify for any quality measures, so that's why they might show gap or show blank. But if we're, going through and maybe we're interested in this particular patient, we can get this patient level view. Again, no PHI, this is synthetic data, but this would be an example. You get some identifiers for that patient, their overall cost, their risk score, their attributed providers, both the sort of standard attribution and custom attribution if you're utilizing that, their current conditions that have been documented, as well as their quality gaps and HCC gaps. So you could actually, leverage this when speaking with a patient to understand, what things should I be asking, what things should I be following up on, as well as an encounter history. So rather than the claims-based history, which is pretty hard generally to sort of reason about, where you have multiple claims for an encounter, one of the things that the Tuva Project does is group those into an encounter group, so that you can understand, more specifically what the patient got, had a visit for, or had an admission for, with that primary diagnosis, encounter type, as well as the costs and facility involved in that care. So that's the main capabilities that we've developed so far. A lot of devils in the details behind the scenes here to bring all of these different domains of data. So quality, risk scores, diagnoses, claims, and different groupings of those domains. And that's really where the Tuva project shines. And then we've created that semantic layer, as Paul mentioned earlier, underneath to make this easy to do in a BI tool. So right now we've implemented this in Power BI, but with the semantic layer, it's certainly possible to implement this in other BI tools. Some outstanding things that we're working through is, some of the dynamic nature of being able to switch between attributed provider, via maybe the MSSP logic or your custom provider, and then implementing the logic for the quality gaps that are very specific to the ACO MSSP program versus some of the more generic quality measures that we've implemented to date in the Tuva project. So those will be available in the future, and then we'll continue to work with our development partners, and then hoping to hear from the different ACOs that are here today about what other areas would be very helpful for us to develop, and this will really be something that we continue to iterate on over the next couple of months. And with that, I'll stop and see if there's any questions. If anybody else would like to chime in, feel free.
Maybe we could ask for questions, suggestions. What else? What modifications would really make this better for you? Would you love this now? Don't be shy. We don't bite. I promise.
I can maybe make a comment. Hi everyone, my name is Dan. I'm a director of product at Stellar Health, and work closely with the Stellar Health ACO, which is an MSSP ACO. This is really wonderful. We really appreciate all the work that went into this. And as somebody who does pay a lot of money for analytics today, this is definitely appreciated. I think the main thing that just jumps out at me is like, if you had this, I would just immediately switch to the solution, is all the benchmarking we have to date. I mean, the thing that really helps our providers engage, when I talk to providers, it's always like, well, my patients are different. Well, we have a high risk patient than everyone else, right? It's hard to create change if you just look at something like a total paid amount or a PMPM amount. You really want some form of comparison, and benchmarking helps us do that, where we find those overspending areas, or that to me is like the primary, and have those be kind of tested or believable, and adjusted to the right kind of population, so we can actually create some buy-in with our clinicians. That to me is maybe like the first area that immediately jumps to mind.
Yeah, I totally agree with that. Dan, I don't know if you know, we got access to the CMS limited data set standard analytic files. And through our data use agreement to access that data, we open sourced 75 machine learning models to do essentially create patient level risk adjusted benchmarks. And so we released those. I think another thing that would be really cool is, one, let's run Tuva not just on the 5% limited data set, but let's run it on the VRDC, on the research identifiable files, the 100% fee-for-service claims data set. And I think there's actually ACO identifiers in that data set, so you can actually see which, which members belong to which ACOs. And so then we could actually do a lot of kind of percentile ranking on different metrics across ACOs on a risk-adjusted basis. That honestly wouldn't be that hard to do. We just have to get access to the RIF and run Tuva on it. So maybe, Will, if you're still on the phone, maybe that's an area of further conversation we can follow up on.
Yeah, we have it's a fairly standard process for getting access to VRDC. I mean, there's a cost per seat, but we can follow up offline. It is notable. It is a research data set. However, it can be used for innovators that are building commercial products. So this would be, certainly a valid use case. We have a process where you go through an approval stream, et cetera, for access to that data. So I think there's a path there.
Yeah, and I think from the ACO sort of dashboard and product perspective, the only thing I'd add is we have the mechanism. If you bring in benchmarks, by patient, by the different Tuva service categories to do that comparison and have that comparison be available in the dashboard. I think we struggled with this question a little bit of there isn't a great standard way to do that for every ACO today. So building that in as an assumption was a little bit difficult because some ACOs just don't have the ability to necessarily do that, especially at a member and like Tuva service category level. But the mechanism is there, and like you can do it at a very detailed level if that's something your ACO is able to do, or something pretty high level if you only have your high level benchmark from CMS. And then obviously, as Aaron said, if we had some more systematic way to make sure that that was available for all ACOs, I think that would be relatively straightforward to integrate.
And one of the things that this allows is at that high level, most ACOs are going to have some sort of financial model that has an implied savings target. And you can use that savings target at the highest level to understand, okay, this is our overall PM target, and then an understanding of how the data distributes across those different service categories can help them distribute that target across those different service categories. Now, that's not perfect in every case, just basic sort of actuarial techniques, but that's what's nice about it is you can just make that visible in your dashboarding tool so that everybody can see, okay, this is where our assumptions are. Is that right or is that not right? And it can facilitate those types of discussions at an organizational level.
Yeah, maybe I'll jump in too. So as Will mentioned, there's a cost associated with the VRDC seat, and that cost is substantial, so we went back and forth at the beginning of the project on do we want to implement benchmarks, and given the level of funding we had, we decided that we would defer that. That is also then one reason why you're paying your vendors a lot of money, because that access is expensive. I think it's good that we have Will here because you also, Dan, spoke about a credible benchmark, right? And we didn't want to just come up with a benchmark of our own, and then we have to convince people that, yeah, this is the Tuva benchmark, it's great. So to the extent that CMS would be amenable to kind of thinking together about what makes a credible benchmark and what is a benchmark that I don't expect CMS necessarily to bless a specific benchmark, right? But kind of finding a way of making benchmarks available and be, if not fully sanctioned by CMS, at least have some sort of a seal of credibility. I think that would be really helpful for everybody.
Thank you.
Other questions or suggestions? This was a very useful one.
I had something, and it has to do with the quality measures and one of the challenges of just having claims as the data source here. I know the data model allows for us to bring clinical data in, but and there's challenges in matching and that kind of thing. So that is just a thing that as we move forward, we know that claims can guide us to whether or not we've closed a measure, but CMS is going to require that you have clinical data to back that up, and are expecting that in the MCQMs. And so that's one challenge I see in using this. I love it. I love how we have the quality measures in here, but I feel like there's a piece there that could really grow, and I don't know how we do that for a free version of this, but that's something that I think is definitely an opportunity.
And there are probably ways that we can think through how to ingest that into, at the very least, that like the dashboard itself, knowing that it's coming from potentially two different sources of data. So maybe that's a topic that, with Joy, you being a dev partner, and Marvin, we can continue to iterate on.
Right, and we're working on developing a solution for that here internally, and so we can definitely talk about how we're implementing that.
So one thing we've talked about as part of this is sort of an invitation for those of you that have ACOs that you're trying to manage and would consider this product. Feel free to reach out to Daniel or Mike or I or Aaron, and we would love to just get together with you. We can kind of reiterate the demo and get your feedback sort of on an individual level over the next couple months, just to kind of make sure we're getting input from a lot of partners. So our dev partners have been super helpful, sort of boots on the ground, but we want to make sure that we're touching as broad a landscape as possible and getting as much feedback. So just kind of extending that invitation.
Help you implement this for free.
What's that?
And help in implementation for free.
And help. Sorry.
Help in implementation.
Oh yeah, right.
Yeah, I think we'll definitely follow up. We'll share the recording to the extent you want to listen to any of my stupid jokes again. You'll have an opportunity to do that, or share with the other people on your team. And we'll also give you a way where you can follow up if you're interested in collaborating or want to get help using it or something like that. We'll have a way that you can engage. So look for that in your email in the next little while. Any other questions or feedback that anybody has? I forgot to say at the beginning, we like to keep these pretty informal, so which I assume by now y'all have kind of gotten the drift. But yeah, any questions or feedback or thoughts from anybody before we depart here? We've got a comment. Kimberly Gonzalez says, at Joy, I really recommend the combination of clinical and claims data to detect documentation gaps. This has really helped our provider get credit for the work completed and meet the requirements for CMS MCQMs. Thanks, Kimberly.
Yeah, I'd like to just add, because Joy and I and Paul and Mike had this conversation yesterday. It is wonderful to be able to have those Medicare CQMs. And for the most part, if no clinical data is required to calculate those Medicare CQMs, you can have them calculated through Tuva, through the normal data process that you have. And I believe, Mike, there's a mechanism to feed some additional data, whether that is clinical or claims data, to be able to close those gaps once you get them closed. So I know there's a good mechanism. In the future, to Joy's point, ECQMs are going to be quite challenging, and I know that's going to be incredibly burdensome for small ACOs and even larger ACOs. I know it's incredibly burdensome to do ECQMs because it requires managing clinical data from many medical record systems and medical practices, and that whole process is incredibly difficult. And I think if we can, if I had my 5 seconds of an elevator pitch, I will say to CMS, keep the Medicare CQMs as long as possible, while teams like Tuva and Penn can step up and help with broader adoption of a technology that will make it accessible for everybody.
Right on. And I see one more comment in the chat. Daniel Rex says, would love some anointed benchmarks from CMS. I'm with you, Dan, on the anointed front. Cool. Well, I think we'll leave it there with just 1 minute remaining. Thanks so much, everybody, for joining. Zeke, Daniel, Paul, Mike, Joy, Marvin, thanks so much for all your work on this. This is fantastic. Hope to see all you guys in the Tuva Project Slack. See ya.
Thank you, Aaron, for hosting.
Yep.
Thanks a lot.
Thanks, everyone.
Thanks, everyone. Thank you.